Welcome to PIPADOR, Revised in 5, a series of short, focused revision tutorials for MRCOG. This tutorial is on the topic of pregnancy and breast cancer and makes reference to the recent RCOG Green Top Guideline number 12, updated in June 2025. Breast cancer is the most common cancer in the UK, with a lifetime risk in the UK of 14%, which equates to 1 in 7. 9% of these cases occur in women of reproductive age. There has been a significant increase in survival rates, with 85% of women diagnosed under the age of 39 surviving more than 5 years after diagnosis. Breast cancer is newly diagnosed in pregnancy in 1 in 3,000 pregnancies, and these cases have a lower ER-positive status with increased HER2-positive status and are more likely to have an aggressive tumour phenotype. Breast cancer diagnosed postpartum has a poorer prognosis compared to that diagnosed during pregnancy. The principles of treatment are that care should be planned as if the patient were not pregnant by the surgeons and oncologists, then adapted with multidisciplinary team input from obstetricians, fetal and neonatal specialists. Using diagnostic and treatment pathways as close to non-pregnant pathways as possible, similar outcomes can be achieved. Any suspicious breast lesion or lump which is present for more than 7 days should be urgently referred within a 28-day time frame. Suspicious breast lesions should be assessed by ultrasound and image-guided core biopsy, not fine needle aspiration cytology. Mammography is reserved for the investigation of the extent of a known cancer. Suspicious axillary lesions can be assessed by image-guided core biopsy or fine needle aspiration cytology. Non-contrast or diffusion-weighted imaging MRI is safe in pregnancy and should be used when indicated, but contrast-enhanced MRI with gadolinium should only be used if the benefits clearly outweigh the risks. PET-CT can be used with caution if the multidisciplinary team feels it may change management. Surgery is safe in all trimesters, and the options include wide local excision, i.e. lumpectomy, or mastectomy depending on the stage of the disease. Sentinel lymph node biopsy can be done with technetium 99M, but blue dyes should be avoided. Radiotherapy is deferred until delivery. If breast-conserving surgery is performed, postpartum radiotherapy should be planned, and reconstructive surgery should be deferred until postpartum. Chemotherapy is contraindicated in the first trimester due to an increased risk of fetal abnormalities, but is safe in the second and third trimesters. Typically, anthracycline and cyclophosphamide is used as a backbone chemotherapy, with taxanes and carboplatin also used. Chemotherapy should be stopped at least 2 weeks before delivery to allow maternal and fetal bone marrow recovery, and the dose should be calculated on the actual maternal weight and recalculated each cycle. Targeted therapies such as trastuzumab or pertuzumab, which are used in HER2-positive cancers, should be delayed until after birth if possible, with the only exception being life-threatening metastatic disease. The risks of targeted therapy include fetal oligohydramnios, neonatal kidney failure, and miscarriage. Endocrine therapy such as tamoxifen and aromatase inhibitors used in ER-positive breast cancers are contraindicated in pregnancy due to the risk of fetal abnormalities and should be deferred until after birth. Bone-modifying therapies such as zoledronate should be avoided in pregnancy unless there is high risk from metastatic disease, and if there is exposure before or during pregnancy to bone-modifying therapies, the pregnancy should be monitored for fetal growth restriction, fetal skeletal development, and neonatal hypocalcemia. The care during pregnancy for women diagnosed with breast cancer should include reassurance that breast cancer can be treated in pregnancy without long-term harm to their unborn child. Clinicians should aim to avoid iatrogenic preterm birth less than 37 weeks, and fetal growth restriction should be monitored for from 28 weeks. Birth should be timed 2 to 3 weeks after the last dose of chemotherapy, and for babies who've been exposed to platinum chemotherapy in utero, neonatal automated auditory brainstem response hearing tests are indicated. Breastfeeding should be avoided if the patient is on tamoxifen or receiving chemotherapy, but breastfeeding is possible following breast surgery and adjuvant irradiation. Prevention of lactation can be achieved with oral cabergoline if required. Here is an example of an SPA sample question on pregnancy and breast cancer. Please try our online MRCOG Part 2 revision question bank at our website pipador.co.uk.